really fast because there's a lot of slides. There's a lot I want to cover, but it should be fun and easy. And I want to make sure I leave a little time at the end. So, but if you want to stop me, feel free, whatever, or just wait till the end. It'll all come together. Dr. Blanian, you can also, I told Dr. Nato, you guys can go to sleep because you've seen this before, but if you don't want to, whatever. I've made a couple modifications. It'll be different.
All right, we'll see you.
Anyway, okay, here we go. All right. So basically, a lot of this stemmed out of the fact that, COVID-19 has had greater impacts in communities of color and underserved communities. In parallel, we saw with George Floyd's murder here in Minneapolis, systemic racism. Sorry, I didn't even talk about the interest. So we're talking about vaccine hesitancy in the workplace and community. Okay. We saw here in Minneapolis, George Floyd's murder really raised greater interest in systemic racism, both locally and nationally. This picture here is just from back in August of 2020, where the orange is, higher ratio of deaths, closer to 2 or greater in the Black population. And so you can see Minnesota was closer to that 2 times rate. Minneapolis is interesting because, we have this history of gun violence here. Back in 1996, when I was in high school, they called this Murderapolis, particularly talking about the north and south side of Minneapolis. I grew up in North Minneapolis, and these are primarily Black neighborhoods. So, and I'm Black, so I think about this stuff like a lot, and it's kind of, near and dear. So, we also have this issue with this paucity of Black male physicians. This data from AAMC, the American Association of Medical Colleges, I apologize, you guys are in medicine, so wouldn't know that junk. But from 2017, said that of all the Black people applying to medical school, only 37.8% of them are men. So, Black male applying to medical school are rare. Black men physicians are rare. But, at the same time, we've seen a lot of data in, medical and public health research showing that concordance of physicians and patients, as far as like, if your doctor and your patient are both Black, that may work better, whatever can help. However, we know that we may not have the proportions to do that out there. And so how do we fit all these things together when we know that communities of color, may have a lot of barriers in terms of seeking healthcare and engaging in healthcare? So is it a problem in Minnesota? Well, let's find out. So on the right up here, we have Minnesota physician data from the Department of Health. And down here, we have Minnesota census data. And so in the state of Minnesota, the Black population is about 7%, whereas across the state, we have about 2.6% Black physicians. And you'd say, well, that's probably highest in the metro area. Well, it's not. It's actually 2.4% here. Now, of course, that's epidemiology. Probably will tell you why that is. But more importantly, in the Twin Cities, the Black population is like 20 or 25%. And so that's like 10 times less proportionally Black doctors than Black people. And so certainly that concordance can't happen. And I'd love to live in a world where, all races and ethnicities of patients worked well with all races and ethnicities of doctors. But unfortunately, systemic racism makes that not always the nicest and easiest thing. So this is an issue that exists even now. So like I said, the murder of George Floyd back in May of 2020 was a really big deal, and it led to both local and national unrest, but also international unrest. I really like this picture in Brussels, Belgium, and you got to ask yourself, like, gee, when would people in Brussels give a hoot about what's going on in Minnesota? And I would have thought never, but the answer is they did. And so people think this is actually a really important thing. And so even though George Floyd's murder was an atrocity, some good may have come of it, we hope. Even back in June of 2020, the University of Minnesota medical students, under the auspices of an organization called White Coats for Black Lives, had a protest at the state capitol, again, talking about the fact that, Black Lives Matter, systemic racism is a big deal. You can see me there in this big bandana looking goofy, but, the point was, this is a big deal for me personally, but it's also a big deal to our communities, and it makes a big difference. And this was all overlaid at the same time that COVID's happening. So then in June of 2020, this is really random, I went to a new barber because I hadn't gotten my hair cut all through the pandemic. And I walk in there in North Minneapolis, this barber shop, and I'm the only person wearing a mask. And I was like, ah! I'm almost freaked out and left. But then I said, well, maybe I should just take this as an opportunity to talk to people about what I want to talk to them about COVID and why they should wear masks and why they should be concerned and whatever. And so I wrote this article for Minnesota Medicine, which is a state medical journal, and talked about what my experience was. And it was just kind of, I don't know, a weird experience where I said, well, I was scared, but I really need to be brave if I want to actually do something for the community. Cool. So then later in 2020, in September, I became a co-investigator on the AstraZeneca COVID-19 vaccine trial, for which Health Partners Institute is a site, even though it's run out of Oxford University. And as part of that, as a Black male physician, and by the way, if you think Black doctors are rare in medicine, they're even more rare in academic medicine, like clinical research. I thought, it'd be important to talk to the community about why they might want to get involved in research. Because, like, if I told some random person, yes, we only studied this vaccine in white people, communities of color are like, I'm iffy about that. Inversely, if I said I only did this study in Black people, they'd be really freaked out about that. So, what you want to shoot for, I would argue, is parity with your population. So, if the population of the Twin Cities is 20%, then you want 20% Black people in your population or whatever. And so, make sure that you have adequate representation so people feel like, well, you tried this on somebody like me, even though we know there's no biological differences of race or ethnicity, but it is what it is. And so then throughout the rest of the fall of 2020, I really was doing a lot of work talking about hesitancy and both in just, as far as participating in research, so like I wrote this article for Minnesota Sports Recorder talking about the fact that, well, yes, everyone's super freaked out about the Tuskegee syphilis study, but by the way, that led to a ton of research protections we have now, the establishment of the National Research Act in 1978, starting with research is voluntary, you can't coerce people, IRBs have to exist, whatever. And, people don't know that. So like I said, even though George Floyd's murder was an atrocity, maybe led to some okay things that came from it, well, the Tuskegee syphilis study was an atrocity, and again, maybe led to some useful stuff that came from that too. And then this was me on the news talking to, about why communities of color might want to participate in research, for the reasons I just described. So then in January 2021, I was doing more of this outreach stuff. There's a picture of me getting my second dose of Pfizer vaccine in January. And, I was on this panel with these other Black doctors talking again, well, gee, for people who are scared about the vaccine, look, the benefits outweigh the risks. And this was like January of 2021, probably before most of the public could even get the vaccine, but we were out there talking about it. And because we know that, again, COVID has affected communities of color and the Black community in particular, even more. So this led my barber so the funny thing is my barber, like when I first went in that time in June, I was asking these guys all these questions, like they were like super suspicious, like, who is this guy? Is he like some kind of narc? Like, what is all this about? But then I kept coming in and talking to him, and more they were like really interested in what I had to say. And then it culminated in January. I walk in and my barber's like, hey, where can I get a vaccine? And I was like, what? Like, I for sure had last talked to him, he did not want one, but he was, then interested. And so then in March, he decided to hold this Facebook Live town hall thing where we had people who were against vaccination, people who were pro-vaccination, including myself. People were kind of in the middle. I'll tell you, the very anti-vaccination people, those people came with like stuff, like, look at this guy's holding papers. They came with citations in hand, not legitimate citations. But I was like trying to like respond to very outlandish claims in real time. But anyway, we streamed it on Facebook Live. It was really interesting. This guy, this one white person in this picture and this camera, that was because he was actually filming for that TPT documentary, which showed this as part of it. And so this led in May to my barber and I being asked by the Minnesota Department of Health to was actually probably in April and May, to then, record some ads about vaccination and talk about, how we feel about it. So here's one. I assume you guys will be able to hear this, but if you can't, sorry.
Me being here in the barbershop and dealing with so many different people,
yeah,
I decided it was best that I go ahead and take a chance and have a vaccine. And then on top of that, wanted to visit with my mother, be around her. And I know you're not in the job of convincing, but you stayed on top of it. Every time you come here, you talk about it, you provided adequate information for me to go ahead and feel comfortable to make a decision to get it.
Well, you're an essential worker, man, and I need my haircut. So, but that's an important point. He is an essential worker. And so, he's somebody who the community is interacting with, and he, needs a vaccine. That was really important to me. And so I thought that one was funny, which is why I showed it. But and my hair is not as crisp looking today. Actually, I'm probably overdue on a haircut, even though I work there. We'll get into that. So then in June, this story came out in the Washington Post, said, hey, the Biden administration, the University of Maryland School of Public Health want to put vaccines on the barber shops. And me and him said, whoa, that's like right what we're trying to do. That's awesome. How do we do it? Well, we were actually a little ahead of the curve. When this story came out, there was actually nothing to do. The program wasn't really out yet, but it was coming. And so we talked to the Minnesota Department of Health and found out that Shea Moisture, which is like a hair care company, was giving out like $1,000 grants to barbershops and salons to hold little vaccine events. Whether that was, probably a 1 or 2 day thing, I guess, for that much money. But Minnesota Department said well, hey, if you want to do something different, we got more money. And I was like, yeah, we do. Because my experience in volunteering at vaccine events prior to this was like, fine, you're at the YMCA, you got like 100 people in a gym, you got like all these booths set up, we're giving away all this stuff, you got people to talk to, we're there all day, and then like 100 people get vaccinated, which I'm not saying that's a bad thing, but I'm saying for that amount of resources, that is a bad thing. So I said, well, shoot, if you're just doing it in the barber shop, we have a couple nurses and me milling around messing with people, like whatever, 2 or 4 hours a day, a couple days a week, like, but you do it longitudinally, week after week after week, that might be better. And here's why. So the issue with these one-day events is if you're worried about social determinants being a barrier to people coming in, oh, people don't have childcare. Okay, well, that might be a problem. Or they can't get off work, or oops, they see it, but they're like, I don't know if I'm ready yet. Maybe I'll get it next time. Hey, there is no next time. So like all those things are going to be bad. And so I thought a longitudinal model, which actually generally was pretty rare at this point, might be a better way to do it. So we did get some money from MDH and started doing it for 6 weeks in a row, Friday and Saturday, 4 hours a day. So that's 8 hours per week. And I had said back then, like, oh, gee, if we get like one person an hour, that's going to be pretty good, like 8 people a week. We did way better than that from the get-go, and it's gotten even better since then. So then after that first 6 weeks ended, we extended another 9 weeks. And then after that, total 15 weeks ended, we extended it to the end of the year. And so now we're probably on like week 18 or 19. And I mean, it's still crazy. Like last weekend, well, I'll get to that. Okay, so basically the thing with vaccine hesitancy or with healthcare research hesitancies, you really got to meet people where they're at. So, here's a picture of some of the nurses and another doctor and the barber and me. I was actually getting my haircut one day while I was there just doing it. Just trying to like, again, show up there. And these are people who look like the people in the barber shop. Health Partners, where I work, put out this story about it back in July or whatever. But again, we're there, we're available. People can show up on a Friday or Saturday. They don't have to make an appointment. It's like a comfortable community environment. The barber shop is famously known as a place in the Black community. And there's other places, church is one. And each community has places like this where people feel comfortable. I mean, any of you seen Coming to America where those guys are like chopping it up in the barber shop and telling all the jokes and stuff? That's a real thing. That exists. And it's like here. So you got to meet people where they are and show them, that you're willing to have these conversations and really take the time to listen to what their concerns are. And so, here's this. This was a guy who was running for city council who was out there advertising for us earlier in the summer. Even though I thought it was going to just be a couple of nurses and us, it was like the Stair Step Foundation, which is a community organization there. I ended up volunteering and helping with it because they've done a lot of stuff with the nursing organization who's staffing this. They got a bus from UCare that was out in front of there and raised visibility a lot. That UCare bus is gone, but now they got their own bus and MDH's bus. And anyway, it like organically grew into this kind of bigger thing than I even planned, and mostly just because we were there doing it. So this was the documentary that Christy was talking about, and the important thing about the documentary was, really who are the people in the community who may be right to address this? Are there people who, either are from the community, who speak the right language, who have the right look? All the above. And so it's not just about bringing it to people, but it's also having the right people, trusted people. And even more than me, somebody who represents the healthcare community, my barber is a trusted person. People will go to him with problems and go to him with things that are going on. And then it got so much so, like where even my specialty, our specialty college, the American College of Occupational Environmental Medicine, they put out this quarterly magazine. They took this picture I took, which like that's my hand holding this, Pfizer vaccine. So by the way, most of the time I'm not giving vaccines when I'm there. I'm mostly just milling around and like talking to people and answering questions. But every now and again, when it gets busy or short staffed, like I'll give vaccines. I don't care. And so I took this picture of this Pfizer vaccine and I posted it on Twitter. And I'm not like some social media maven, but that thing got like 10,000 likes. And I was like, wow, like I don't know why people were that jazzed about this picture. And so then they asked me like, hey, can we use this picture and feature you in this thing? And I was like, I guess so. But the good news is that's how you get the information out there. So then more recently, this is last weekend, I was giving shots yet again. And so that Saturday, we gave out all of our vaccines because apparently people are having a hard time scheduling boosters now. I didn't realize that was a problem. Well, people like the fact they didn't have to schedule anything. And they were getting $50 incentives from MDH too. And so this is my little sister and this is my little brother, and they both happen to show up that day for a variety of different reasons. But anyway, and that's why they don't care that I use a picture. But the funny thing is, like, that's it. People are there just coming to, get a vaccine. And it's convenient and it's accessible. So, there you go. Anyway, so how does this align with medical ethics? So these are the 4 principles of medical ethics. And we know starting at the top, and this is true for research too, patient autonomy is number 1. Our job is to give people good information. But we know people will never be as smart or as wise as us about medicine and everything involved. And so really it's more than autonomy, it's really about empowerment. We have to partner with people and help them make decisions consistent with what their goals are. Now, following that, we have to balance the benefit the potential for benefit and the risk of harm. That's beneficence and non-maleficence, that balance. You shouldn't offer anything that doesn't have the potential for benefit, and you shouldn't do something that's really likely to harm somebody. And vaccines, thankfully the data is really good that they work really well, but people have anxiety about stuff, so we got to make sure we're not stressing people out. And justice is certainly not as last here, but not least. Some people think, well, that's just like, okay, don't offer care to somebody you want to offer to somebody else. So like, for example, some people might think our last president who got COVID and ended up in the hospital and got like every experimental and expensive treatment in the world that nobody else had access to, that may not be consistent with the tenet of justice. I would also agree with that. However, I would say, look, justice is outside of the exam room because there are all these factors, social determinants that affect people. And if those are inequitably distributed and we know those impact patient outcomes, then shouldn't we have something to do about that too? And the answer is yes. Okay, so vaccine hesitancy is a historic problem spanning way beyond COVID. In fact, going back to the history of vaccines even being invented. And I'm not going to talk about that history too much other than to say that people have been concerned about this from jump. And in part, it's because you can't really see the diseases affecting people. You can't really see what the vaccine's doing. And so people are like, oh, why are you going to put this weird stuff inside me? Or more specifically back then when it was like smallpox and they were giving people cowpox in the vaccine, they're like, oh, why am I going to let you infect me with this disease? No, forget that. So there's always like a variety of concerns. Now, in the late 90s, this study came out from Andrew Wakefield. You guys have heard about this, linking thimerosal, a vaccine preservative, which has mercury as a molecular component of it, with autism. That study has been retracted from publication several years later, and that doctor has basically been ostracized from the medical community. And yet, unfortunately, the persistence of at least that one thing has continued on to this day. In fact, that doctor still gives talks to like many underserved communities, like the Somali communities invited him here to talk several times, even in recent years. Now, I will also say, here in the US, we are spoiled. I mean, this is probably worldwide, but especially in the US, we are very spoiled that we don't have experience with infectious diseases having very severe consequences, like President Roosevelt being in a wheelchair because of polio. We don't see that now because we don't got polio. I have to tell people, oh, by the way, measles can cause severe brain disease that potentially can kill you and or have long-lasting consequences. We don't see that anymore because people are vaccinated against measles, etc. Kids nowadays never had chickenpox. I mean, I had chickenpox when I was like, I don't know, 8 or 9, but by the time I was like graduate high school, they already had a vaccine for it. And now kids don't know about them anymore. So we are approaching it from a perspective where we're not seeing that. In communities of color, Tuskegee is the big one, but people know about Henrietta Lacks and the HeLa cells. And if you don't, read The Immortal Life of Henrietta Lacks, and it can answer all your questions. Now, who you probably don't know about is Marion Sims, who is considered like the father of modern OBGYN. And this guy developed some really elaborate, awesome, amazing surgical techniques. But how? Experimenting on slaves who most likely, almost certainly, did not give their consent. Dun, dun, dun. And so we know, other hesitancy comes from systemic racism. I joke, and it's not really a joke, that people of color walk around with this like low baseline level of anxiety no matter where they go. If you go to Target, you go to the bank, you go to the doctor, you're always like, it's iffy. And so that's something that becomes a problem too when you're facing big institutions, healthcare, government, etc. And then there's all these peripheral traumas, law enforcement violence being a big one. Like me seeing George Floyd on TV get murdered 8,000 times in a row. That does not make me feel better about my own risk or my kids' risks or my nephew's risks or whatever. Those are real things. And like I have had bad experiences with the cops. I've had good experiences with the cops too. So I don't have a problem with cops. I'm just saying, but this is a real thing in society that we have to face. And we have to face that it affects our patients. So let's just look at it epidemiologically. So life expectancy at birth, and this is just for 2006, 2009, Hispanic females do the best and non-Hispanic white females are second best, followed by Hispanic males and non-Hispanic black females and non-Hispanic white males. And then way, way, way down, I mean, those are big different numbers, non-Hispanic black males. So I'm probably going to die earlier than most people Congratulations for me. But it's still a longitudinal problem. You go back to look at 1970 to 2009, okay, white females are way up here. Black females are appreciably lower, great. White males are close to the level of black females, interesting. And then all the way down to black males. And so this same disparity or inequity has been seen even back in 1970. It's narrowed a bit now, looking at 2009. But, you can still see a huge gap between these. So even though life expectancy for everyone has improved, it stayed worse for Black people and people of color generally. We see higher chronic disease rates in the Black community, whether you're looking at hypertension, diabetes, or stroke, across all age groups, also probably notable. And again, that speaks to the prevalence of systemic racism affecting people well beyond, direct means of things causing high blood pressure or strokes, etc. Similarly, we know that being Black just is more likely to kill you from all causes. In JAMA, or was it NEJM? I can't remember. There was a paper like January of this year that said essentially being Black has an odds ratio of like 1.27 for dying from all causes. So again, I'm 27% more likely to die than anybody else just for whatever reason. Sucks to be me, but here we are. Okay, so why does race matter? And again, I'll say it again, structural racism. Now, I like this quote enough that, I'm going to read it. I don't like to read quotes that often. I'm going to do this one because, well, I'll tell you why. The totality of ways in which societies foster racial discrimination through mutually reinforcing systems. If you learn anything today, learn those 3 words, mutually reinforcing systems of housing, education, employment, earnings, benefit, credit, media, healthcare, and criminal justice. Wow, that sounds like kind of like social determinants of health, I think. Yeah, it is social determinants of health. And so we see social determinants of health is broken up into these 5 domains: economic stability, neighborhood and built environment, health and healthcare, social and community context, and education. And so all those things I described easily fit into these boxes and are things that we know affect health outcomes. Now, I like this causal web on the right now. For you public health students, I wouldn't normally say this as lecture, but I will now. I think part of the fun of making a causal web for epidemiology researchers is like to make it as convoluted as possible, because I think most of the time I think you can like take these and like stretch it out and like make it much more like linear, but people like to make it look like the more messy it is, the more likely you are to get accepted or published, I think. No, I'm just kidding. Anyway, so at the middle of this web of causation, you see increased maternal and infant mortality. And then you see, factors affecting that: food stability, neighborhood demographics, rates of incarceration, and then extrapolating those larger to bigger issues like slavery, Jim Crow laws, the 13th Amendment, redlining, which is the practice of not letting people who aren't white necessarily to buy houses in certain areas. That's crazy, I know. All of those things have an impact on maternal and infant mortality rates. And to this day, if you don't know it and you're in public health, you should know it. Black women have like way worse rates of maternal and infant mortality than white women for a million different reasons. And that's like proven all the time over and over and over again. Some people would say racism, and I would agree with this, is its own social determinant of health. And again, it's because I would say this fits like right in social and community context. Because again, it's one more factor causing avoidable and unfair inequalities. If you want to be super new school, colorism is a social determinant of health. People with darker skin, regardless of race, have problems. And people with darker skin than me who are Black have worse problems than me. That sucks, but it's true. We know that racism impacts mental health, and not only the stigma that it's experienced culturally, but how clinicians interact with them, what kind of support they have, how people seek help, or if they seek help, how people cope with it on top of the existing stressors they already feel in life. Yeah, those are real things, and this is a problem. We know that it affects us as clinicians. We have implicit bias. That's been proven too. We know it impacts our medical decision making. We know it impacts our communications with patients. So I like this picture over here because it's like, okay, physicians have implicit bias, and that leads to immediate outcomes of like people mistrusting or having dissatisfaction with their care. And in long-term outcomes, people have low adherence or low healthcare utilization. What's missing in this gap? Oh, how the physician talks to me during my medical interaction. No surprise there, but it's true. And the problem is people go through this like cultural sensitivity or cultural competence training, but that stuff doesn't talk about why people feel this way. And if you haven't figured it out, today I'm talking about why people feel this way to some degree. And again, peripheral trauma is yet another thing. And by the way, I'll credit a little bit Rachel Hardman with that, because I like her paper on peripheral trauma from 2019 very well. And again, we know harmful research atrocities are an issue. We know law enforcement violence is an issue. There's a bunch of other ones that are issues, but we don't need to go there. This isn't all about that. And so, as I mentioned, we know social determinants have a greater impact on health outcomes than all the things outside of clinic. So this graph, if you want to believe ICSI, but you can believe whoever, says 20% of health outcomes are from what we do in healthcare. And the other 80% are everything outside of healthcare. If you look at all the literature, that 20% actually generally is like in the 10 to 50% range. But the bigger point is that means a minority of patients' health outcomes are impacted by what I do, and a majority of patients' health outcomes are impacted by everything outside of the clinic. So going back to what I was talking about justice, If I know all these things are affecting my patients, like, by the way, even though my diabetic patient is prescribed insulin, he can't afford insulin, that's a pretty darn big deal. And I would say part of justice is us doing something about that too. How do we make insulin affordable for patients who need it? How do we make housing available to patients who need it? So that way they can actually treat the diseases I'm interested in treating them for in clinic, as opposed to like them being like, yes, I hear what you say. That's really great and all that you want me to take medication and change my lifestyle, but I'm trying to figure out like, how do I eat today? So now let's make it fun and talk about occupational health disparities. So I like this paper by Stanbury and Rosenman from 2014, only because it just talked about the common occupations for different races, white, black, Asian, Hispanic. And, you know, the big takeaway here, and you guys can look at these slides later. Actually, I probably need to send Christy these new ones, but that's my bad. Is, you know, white and Asian workers in this study had more white collar or higher order jobs where they were having probably less rates of injury, and black and Hispanic workers were working more low class blue collar jobs where, and by the way, in COVID parlance, would be more essential workers without the ability to work remotely. That's a real thing. We saw this translate in the same study where they were just looking across like, well, what's the incidence for these populations for these occupations? And again, looking under the white population, oh, look, these are EMTs and paramedics, and I guess there's roofers and mobile heavy equipment operators. But then if you go under black, it's like, oh, laborers and freight and stock movers and heavy tractor trailer drivers. And under Hispanic, oh, these are a lot of the same truck drivers and food servers. And so the point is, again, you're seeing a greater distribution in those populations of people who might be more likely to have injuries. And so they looked at that too. And they said, okay, well, how does silicosis and deaths and pesticide injuries and burns and asthma look? And oh, look, for black people, we have rate ratios of like 5.5 for silicosis, or 1.25 for burns, or 1.9 for occupational asthma. And for Hispanic population, it's like 1.5 for death. 1.5 for death, that's like crazy. You're like 1.5 times more likely to die in your occupation if you're Hispanic. That's nutso. And then, you know, 4 times higher for pesticide injury. That's scary, man. And so Sears and these folks in 2015 looked at 90,000 people in Arizona, California, Florida, New Jersey, and New York, and across a 6-year period. And again, saw that for all occupational injuries, for falls, machinery hazards, motor vehicle accidents, assaults and homicides, there were increased rate ratios for Hispanic and black workers. Interestingly, for whatever weird reason, black workers were particularly at much higher risk of getting assaulted or killed. I don't know why that is. I'm actually very interested in that fact, and I need to probably go back and see what followed this to why that is. But suffice it to say, again, black and Hispanic workers generally, and this wasn't specifying by occupation, but are at a greater risk of occupational injury. And Steege and those guys in 2014 looked at 1.7 million workers with about more than 200,000 non-fatal injuries and 27,000 deaths. And really the takeaway here is, oh, look at these unadjusted and adjusted odds ratios of, of occupational injury. You know, high for Hispanic workers, high for black workers, high for indigenous workers. Does that surprise you? And that correlates with, oh, look, not having high education, or even being born in another country, or even outside of the continental United States, or making less wages. Surprise? It's not a surprise. So why does that happen? Well, we know these folks are in precarious work situations. You have seasonal jobs. You know, they may be undocumented. They might be putting together multiple part-time jobs to like make one full-time like paycheck, even though people, you know, some jobs don't give you health insurance. Some jobs may give you health insurance, but you're not able to afford the copay. Sometimes jobs don't have workers' compensation. Sometimes people aren't given the right safety equipment or the right safety training, or it's not in their language, or they're not there at that time, or you know what, culturally, for whatever reason, their friends tell them it's lame to use a respirator and they just don't do that. I'm pretty sure in public health you've heard that before, and if you haven't, you will. But basically, these same issues exist across underrepresented groups, whatever they are. And so now we have to think about, well, are we capturing the right people and how? Well, okay, the problem we've seen, at least in clinical medicine, is, you know, up until a couple of years ago, in our electronic health record, you could choose one race: white, black, Asian, Native, other, multiple. But, you know, you couldn't pick more than one of those. And ethnicity was like Hispanic or non-Hispanic. But, you know, race is like a social construct. So what does that really even tell us? And if race is social, then certainly wouldn't nationality be? And then we end up asking people, well, what's your country of origin? Now, I've seen in reality, that's not a clear question to people. Like, you'll talk to somebody who was born in Somalia, who now is a U.S. citizen, and you say, where are you from? And they say, oh, I'm from the United States. And you're like, no, where are you from? And the question they're really asking is, where were you born? people ask me that question all the time just because of my indiscriminate brown color, and I'm for sure from here, but you know, would they believe me? I don't know. Anyway, so we asked people about country of birth, and then, you know, in gender, a lot of people aren't historically have really been asking binary gender categories, which is again problematic because various gender categories may be more likely to discrimination, harassment, bullying, or other occupational hazards that we may not even be aware of yet. We've seen this discordance in self-reported data and data in electronic health records, both in a study done in the VA in 2009 or in this primary care study in 2015, where again, generally speaking, what we see is EHRs have low sensitivity and high specificity relative to the self-reported gold standard data. We did this in our clinics with like 800 people and saw the same thing. Sensitivity is really low and specificity is really high. So for practical reality, because I know you guys aren't all like studying epidemiology every second of every day, essentially this means that if the EHR says you are black, you are for sure black. If it doesn't say you're black, we don't really know. But this paper actually is in the process of getting published right now, so I'll share that with Christy at a later date. So you guys will probably be graduated from this class and won't care. But anyway. So we saw this in practical reality, though, because one of our prior residents, who has also taken this class, looked at 2 years of our clinical data and found that Hispanic workers were had 3 times higher rates of low back injuries and about 2 times higher rates of upper extremity injuries. But again, going back to my point about data gaps, what does Hispanic mean? Does that mean undocumented? Does it mean Spanish speaking? Does it mean from Mexico, Spain, Dominican? Like what? I don't know who those people are. And what jobs do they work in? Really didn't know that. So it was an interesting finding, but then portended us doing this other work to figure out where are those gaps at on who we're able to identify and how. And we know these same occupational health disparities have perpetuated into COVID. So this is a chloropleth map, or more affectionately known as a heat map. On the left, we're looking at maps of incidence. On the right, we're looking at maps of mortality, where B is Black, C is Latinx, E is Indigenous. And again, you see higher rates, higher incidence of COVID and higher mortality of COVID in these communities of color, consistent with what I've been saying for the last 30 odd minutes. Now, more interesting yet, the last quote I will read for the day, talking about occupational health disparity, says, as with all diseases for which workplace environment is a root cause, the most marginalized workers with the least power and resources, that is, people who are undocumented, incarcerated, people of color, women, lesbian, gay, bisexual, transgender, or queer, you know, are underrepresented groups, are the least likely to have access for testing for infectious diseases and the most likely to be missed in cohort enumeration. Meaning, we aren't going to test these people and we're not even going to pick them up when we're trying to look for them. Dun, dun, dun. Which is yet another disparity that you can't even find the people who are having the problems. So I like this picture of environmental lung disease, where, you know, this is just showing like different levels of impact. And again, I'm going back all the way to what I said, mutually reinforcing. And so it's physical activity, it's cultural beliefs, it's racial biases, all these things at every different level, and they stack on top of each other. Being poor and being Black and being queer and being unemployed are all different factors, and they're not mutually exclusive, and they're not living on an island. They are all stacking on top of each other, and they're all make each other worse. We know that in occupational health, there's mistrust of the same institutions and systems that I was talking about before. And so this study was looking at the discordance between people reporting injuries themselves and their job reporting the injuries. And so what we noticed was, I didn't do the study, they noticed was both Hispanic and non-Hispanic Black workers, there was a greater discordance of, you know, occasions when either they themselves reported it and their job didn't report it, or when their job reported it and they themselves didn't report it. Scary. And so I looked to see, like, well, are there a lot of studies about workplace vaccine hesitancy? And the answer was not really. Now, this wasn't the only search I did. I did actually 10 different searches like this, but suffice it to say, people have not looked at this. And to be honest, actually, there's, I'm working on a study for looking at vaccine hesitancy in firefighters right now. And there's like tons of news stories out there talking about firefighters, police, EMS have great degrees of vaccine hesitancy. Not really literature on that. And so we know some of this mistrust, again, is a function of peripheral trauma. I've talked about some of the research stuff, but we know infectious disease stigmatizations exist in the past. Back when, you know, AIDS was more of an epidemic, there was stigma against the gay and queer community. Now, with COVID-19, people talked about, you know, the China virus, and this really led to a lot of Asian American hate and violence in the last year or so. In clinical medicine, you know, people of color aren't believed. We talk about, oh, this person's like drug seeking or malingering, or God, this guy's like such a difficult patient, only because people may express things in different ways or may not be telling you stuff in the way you want to hear it. And that really happens. Socially, again, we talked about law enforcement violence a little bit. Redlining, that's what's shown in this white box. I mean, these are laws that said, like, if you aren't white, you cannot buy this house. Cultural appropriation, things like the Redskins logo, which certainly upsets people on a daily basis. I know that we're getting rid of that, but that's the point I'm making. It took like that long. We've known about this forever. And immigration stigma is an obvious one. All of this is compounded by the information overload we're experiencing nowadays. The World Health Organization says we're living in an infodemic. And so they're saying, like, there's too much information, whether it's good or bad. And they define that as within a disease outbreak. But we know this was a problem even before COVID-19, where with the internet and the 24-hour news cycle, there's more and more access to information. There's more and more access for people to find information supporting whatever they believe, whether it's right, wrong, good or bad or ugly. And there's people aren't experts on like assessing sources and lateral reading and all that kind of stuff. So we need to help them. So I always joke about this one and saying, like, well, you know, if you're looking for stuff on the internet, you'll find it. And in part, Google and other search engines are actually perpetuating that echo chamber effect because it's going to show you things that you've searched for before. And so if you are looking for this kind of stuff, it's going to keep showing you that. And if you're looking for CDC, it'll keep showing you that. And so actually, search engines, I think, are doing a bad job of helping people see other sides of arguments. But where do employees get information? Well, some of this comes through safety training, whether formal or informal. Some they hear from their boss, some they hear from their friends at work. But out in the community, you know, they might talk to their union, they might hear stuff in the news, they might see stuff online, they might talk to their friends and their family. And the point is, there's a million different sources, but for different people, they may trust some of these sources differently. And so really, we have to be careful for this echo chamber effect, which academically people call cognitive conservatism. And that's our natural resistance of changing our own sense of self-concept, and then also seeking information sources that reinforce what we already believe also. Because, you know, I want to know that my beliefs and values are true and well supported by stuff in reality, which may or may not always be true. And in specific groups, we see this to be worse. Some groups will reject good information because they don't trust the institution, saying it like, oh, I don't trust the government, so I don't care what CDC says. Whatever they say, I'm just going to believe the opposite of that. And unfortunately, that's like a type 2 error, you know, a false negative. Somebody believes it's negative even though it's true. And similarly, that same mistrust may lead you to believe other sources that aren't as accurate. And, you know, regardless of whether they are accurate or not, and, you know, your friend's telling you, or your best, you know, favorite person to watch on TikTok or whatever, and that's a type 1 error or false positive. Like, I believe this thing, even though it may or may not be true. And so underrepresented groups tend to have this attraction of what we would call conspiracy theories because they experience chronic social devaluation. I am trying to figure out why my life sucks so much worse than everybody else's, and I want to explain that. Well, now I can find these great, attractive, alternative theories to explain that because I want to manage that sense of devaluation for myself. There's a reason that this exists. It's not just random and bad. And unfortunately, us calling it conspiracy theories only amplifies that same devaluing. So how do we deal with this? Well, one, we got to address these. We got to figure out who's at risk, and that's some of the data gap issue. We have to deal with this issue of information overload and make sure good information is available to people and kind of fight some of the myths. And then, you know, both in healthcare and in the workplace, we have to, you know, show that we know there's a problem, and we have to hear people's concerns, and we have to like show that we have the resources to do something about it. And then we have to gauge people at whatever level they're comfortable to get this information. Or more broadly, just remove the barriers. So this is everybody's favorite picture. So on the right, in reality, people want to watch this game, and they all have different degrees of resources to do so. And equality is like, well, then we will fairly give everyone the same resource regardless of what happens. And people say, well, new school equity is like more outcomes driven. So let's give people the right resources to make sure that they can all see the game equally. And I'd say, forget the resources, forget the fence, just remove the barriers. And so then we don't have to like give people health insurance and worry about, you know, supporting them, because that's not even an issue or whatever it is. So really, at the end of the day, inclusion starts with trust. And so it's one thing to, you know, ensure diversity. We have, you know, so many Black people, so many white people, so many whatever people here, but beyond diversity, you have to give people the venue to be included, to feel like they belong and feel like their voice can be heard. And that's where you suddenly can start building the trust where they can say, okay, my perspective is represented by someone else here in a way that I don't have to share it myself, and I know it's being heard and being talked about. So how do we do all that? Well, don't assume anything. People have different degrees of lived experience, People have different degrees of knowledge. Just because people look black don't mean they are black. Just because people are black don't mean they think a certain way. Just because somebody's white don't mean they think a certain way. Men and women don't necessarily all equally. All women don't think the same thing. All men don't think the same thing. Maybe that's obvious, but I'm just telling you, people will jump to these conclusions. You have to listen. You wouldn't believe that from hearing me talk for 45 minutes straight, but believe it or not, I am a good listener. And taking the time to listen to people opens the door for them to feel comfortable and to trust you a little bit. And think about that. Well, whether it's what I want as a clinician and what they want may not be the same thing, or what, an employer wants, an employee wants may not be the same thing. And so those competing interests are worth talking about. Or like, oh, well, my job is mandating I get a vaccine, but they're not going to give me time off if I get sick. And I'm going to get written up if I don't show up. And by the way, I might get fired if I don't show up. And it's like, well, then, yeah, do I really want that vaccine? And making sure that people have access to find the resources they need, and also really making sure people feel enough empowerment that they can take care of themselves. So again, it's all about building and rebuilding trust and making sure people are adequately represented and their points of view are adequately represented. Now, this point about restorative versus retributive justice is important to me, especially as we talk about workplace safety, because ultimately, there's a lot of workplace transgressions for which people will get written up for, like you were 5 minutes late or whatever. But that really erodes trust over time when people feel like, well, I can only do wrong, but I can't do good. And, literature will tell you, whether it's in the workplace context or criminal justice or whatever, we should really pursue restorative justice for minor things. Oh, you were 5 minutes late. Well, why don't you sit down now with me, your supervisor, and HR, and we'll tell you why it matters to us that you're 5 minutes late, because you made 10 less widgets today, and over the course of a year, we make X amount less money, and now I have to fire somebody. To you, oh, you're 5 minutes late because you had to drop your kid off at work, and that you're always going to be 5 minutes late, and that's a problem for you. Well, gee, can we just make your schedule 5 minutes later on both sides, and problem solved? And you did that without eroding trust. In fact, building trust, and everyone's happy. Now, look, if you're embezzling $1 million from your company, we got to bring the hammer down. So it is what it is. But we know in criminal justice in the United States, we are very much all about retributive justice. So again, figure out what level you need to engage people, and figure out, do you have it in the right language? And again, be transparent about these reasons that you want to do stuff. Oh yeah, look, the reason we care about safety, the reason we care about vaccines is, if people die and get sick here, then, our insurance modifier is going to go up. We're not going to get contracts. OSHA is going to be up our butt, whatever. And the person will say, well, here's why it matters to me. And again, have that conversation to build trust. So in healthcare, we hear from people like, oh, I don't trust doctors. I'm like, dude, I don't trust doctors either. No, I'm just kidding. But we know that healthcare historically has not had communities of color best interests at heart, and certainly has harmed communities of color. That's a real thing. I have to validate that. But okay, fine. You don't trust me. You don't trust healthcare. Who do you trust? And let's talk to them or get them involved. Or more importantly, you came to see me. So what exactly do you want me to do? But okay, forget all that. I can't change what happened in the past. I'm trying to make sure I can do my best for you today, right now. And fine, even more than that, if it's not me, who would you feel more comfortable with? A black doctor, a woman doctor, or whoever doctor, whatever. Like, who do you want to talk to? I'll help you get there. People say, well, I don't want to be a guinea pig. And I'll be like, well, so now in the research context, this matters more, but certainly in healthcare, like patient autonomy, dude, and in research, that's true. Research is voluntary. Like, you can choose to say no to anything. Like, you are your own agent. You don't have to take anything I say. And, when in a clinical context, I really have to be clear with people, like, this is not research. I'm not testing things out on you. This is like all approved standard of care stuff. It is what it is. And then again, explain to people, look, even though there have been research atrocities in the past, theoretically, we have very good research protections now that prevent that from happening. And if you're talking about research for this stuff, again, the same talk about research protections can go a long way. People say, I don't trust the government. I say, I don't trust the government either. No, but I like to leave the slide so you can read the little list Homer has there, which is pretty funny. But more importantly, again, I know that the government has not always had communities of color interests at heart, and certainly has harmed them. But more importantly, as your doctor, your nurse, your social worker, your public health agent, the government does not control what I do necessarily, maybe in public health. But more importantly, look, government entities are the ones who are approving medications, like through the FDA. Nobody can tell me how to prescribe something. They're certainly not going to, and I'm not going to listen to them if they do. And at the end of the day, I'm not asking you to trust the government. I'm asking you to trust me, at least a little, just right now. And again, empowering people, because people want to say, well, my body can heal itself, or I don't want to take a pill. Great. I don't want you to take a pill either. That's like a last resort thing for me, and certainly don't want you to have surgery. But if you waited till you're 60 years old and now your blood pressure is 220 over 120, I'm sorry, dude, we're gonna have to probably do something different. And so it is what it is. But the human body does a good job of fighting and protecting against disease. But again, if you wait long enough, that may not be enough. And really, our job is to try to educate you so you can make the best choices and prevent this stuff on your own. And again, at the end of the day, if you showed up on my doorstep as a doctor, if you don't want medication, like, what do you want? And then people say, I do my own research. This is like my all-time favorite thing. And they say it all the time with a straight face, looking at me, who's like, dude, I went to school for like 8,000 years to like talk about this stuff. But okay, let's look at your research. And here's the thing, I'll ask them, I say, like, let's look at your research. And the bad news is when people say that, they almost never have that research offhand. So that sucks, but it is true. But then I say, well, look, I'm really glad you're so interested in trying to learn more. Let's talk about that. And by the way, did you know there's bad information out there? And you know how to check the sources? Who benefits from the messages they're telling you? Some of these like naturopath doctors who are like, don't take vaccines, but take all these cool supplements. Those people are making like thousands of dollars a day. Like, that's a real thing and exists. And by the way, I don't make thousands of dollars a day, in case that was a question you had. But okay, fine. If you don't believe the government, and you don't believe me, health partners, or whatever, check out some other local organizations. The Minnesota Association of Black Physicians, the Minnesota Medical Association, the Minnesota Nurses Association, the Minnesota Association of Family Physicians, like whatever. There are different organizations that are not all necessarily evil and run by the Illuminati or whatever it is you're concerned about. And so, you can find good sources out there that may be more consistent with your values or what you're seeking. And so we know the workplace historically has always been a really good place to intervene on health promotion stuff, whether it's smoking cessation or changes in diet and exercise. And so there's lots of ways we can do it by starting with, what the assessment of what's going on there right now, planning, how do you want to put this in place, actually implementing it, and then evaluating what the results are. And this looks just like your PDSA QI cycle, because essentially that's what it is, but in the workplace context. I just have this last slide showing the workplace health model more in sort of an actual like implementation context of how you do it, but it's really the same thing I just showed on the last slide. I just thought this one was a little bit different and interesting. So again, we know the workplace is a great place to actually intervene on things like vaccination and hesitancy, and we should do so. And you as a public health agent can potentially empower employers to do that in a way that's going to be helpful, because we know right now people are really worried about these vaccine mandates and they're getting really mad about that. And I would argue, I guess I believe in vaccine mandates in my heart, but that you're going to get pitchforks over it. And so the question is, how do you set up a world where you give people all the tools to make that decision in the right way for themselves? And that's, I guess, the balance we're fighting against right now. So what came out of all this? Well, now I have a grant, like I said, doing some surveying hesitancy in firefighters. One of my colleagues, a behavioral health researcher, has submitted a more broad vaccine hesitancy grant. And this is something like where I never planned on being a vaccine hesitancy expert by any means, but organically I am. And here we are. So thank you.